This talk actually developed out of my attempt to review the guidelines, the changes in these guidelines for my practice group, which is Joy already mentioned. Eastern Shore, I've got some slides that follow here that do a little bit of a demonstration, but the Eastern Shore Rural Health System is actually a series of 5 community health centers that run the length of the Eastern Shore of Virginia. We are currently at about 40 providers, most of whom are family practice, internal medicine, some nurse practitioners, some PAs. I'm actually the only OBGYN in the group. And so I was tasked with trying to condense down these changes, which are admittedly somewhat cumbersome and complex. My hope is that I'm going to be able to condense this down and give some background on this and make this a little bit less frustrating for folks. These are the references. Just in case you didn't know, there's a society for everything. The first one is the American Society for Colposcopy and Cervical Pathology. The third of these is the ACOG Practice Guideline, and Joy and I were talking this morning. That document is going to print out to about this thick, and most people's eyes are going to completely glass over at that. But the good news is that the last reference is a mobile app, and we're going to actually demonstrate that in a little bit. Where you actually can enter in your patient's age, your pap smear results, and it's going to actually bring up an algorithm that's going to actually really simplify your life compared to trying to go through one of those bulletins. So kind of the background on all of this is really a change in our understanding about HPV. HPV is actually extremely common. It's easily transmitted. Most women are going to actually at some point be infected with HPV, but most are actually not going to develop cervical abnormalities. The issue is when that infection is persistent. Transient infections are not the problem. The other issue is immunocompromise, and smoking is probably the number one. And if the pap smear is the least bit abnormal, I really use that as an opportunity to really hone in on the importance of smoking cessation. And the example that I actually frequently use is back from when I was a resident. We had a patient show up who actually, in her case, it was genital warts, completely covered the vaginal introitus. We got her to quit smoking, and by the time we got her scheduled for laser ablation, which was about 6 weeks later, she came back for her pre-op exam, and they were gone. This was like a 26-year-old. So smoking really can, getting them to quit really can be an amazing treatment in itself. So there are 2 classes of HPV. One is the oncogenic or high risk, the non-oncogenic. Our concern is obviously the high risk. Type 16 and 18 being the most carcinogenic and the ones that we're really concerned about. 6 and 11 are the ones that are responsible for most warts. And when we get a little further here and we look at some of the HPV vaccines, you'll see that that's where the target is. Again, 79 million Americans infected with HPV, 14 million each year, mostly teens and young adults. The good news being those are the folks with the immune systems that actually generally are going to clear this. And almost every person who is sexually active is going to acquire HPV at some point during their lifetime, according to the CDC. So again, there are 3 vaccines currently licensed. CDC is recommending routine use of these in boys and girls aged 11 or 12. They're bivalent, quadrivalent, and then the newer non-valent or Gardasil 9. Just very recently, October 19th, the recommendation was to change to a 2-dose vaccination series 6 months apart for those that you're starting out at ages 11 to 12. Unfortunately, if they had already started on the 3-dose series, that's to continue. But for those that you're just starting out, we actually have good evidence now that we can cut that back to a 2-dose series. So most women with intact immune systems are going to be able to clear HPV infections within 24 months. and that is really kind of the onus to, or the background to why the changes were made. The issue is more persistent infections. Persistent infections are the ones that are going to result in cervical dysplasia or worse. So low-grade dysplasia, CIN1, is generally the result of an acute infection, not a chronic infection. High rate of regression to normal, and once confirmed, and generally what that means is that colposcopy and biopsy has been done to know for sure that that's what you're dealing with. Expectant management is what's now recommended. The days of following things with pap smears every 3 months, every 6 months are gone. The data does not support that. Actually, the answer is generally 12-month repeat. High-grade dysplasia is a different story. And there's approximately 3 to 7 years for severe dysplasia to progress to an invasive cancer. It is an indolent disease course. It progresses slowly, and so that's the justification for less frequent but more focused testing in general. So current screening guidelines. The answer is the recommendation is to start pap smears at age 21 regardless of the patient's sexual history. Yes, we're going to have the 18, 19, 20-year-olds that are very sexually active, multiple partners. The current recommendation is pap smears should begin at age 21. It should be avoided prior to that because there is an extremely low risk of cancer, and that may lead to unnecessary and harmful evaluations and treatments. Now, that's not to say STD testing, and of course, there's always the idea that people show up for a pap smear, and really what they're there for is STD screening. So those ideas have to be separated. So currently the recommendations for routine screening from ages 21 to 29, cytology alone every 3 years. Ages 30 to 65, cytology with HPV co-testing every 5 years is preferred. Cytology alone every 3 years is acceptable. And this is unfortunately where I'm going to have to put in a caveat. Sometimes the guidelines that are recommended don't necessarily match up those that you have to use in practice. And Adrian and I were talking about earlier, one of the ones that we were faced with until very recently was our health departments in Virginia still had a policy on the books that they wouldn't refill people's birth control pills unless they had an annual pap. That actually has recently changed. In working in a federally qualified health center, one of the issues I've run into is that the UDS uniform data set that the federal government uses still requires a pap smear every 3 months regardless of HPV status. So after I had spent time getting my colleagues to recognize that the ideal is cytology plus HPV testing every 5 years, we then had to turn around and say, yeah, but the feds say we're going to have to stick with the every 3 year anyway. Over age 65 or after a hysterectomy that was done for a benign indication, there is no reason to continue doing pap smears unless they previously had a CIN3 or a cancer, and then you would continue it every 20 years. Yes, I recognize that after hysterectomy sometimes there can be small amounts of cervical tissue left, but again, the evidence just does not support continued pap smear screening for someone who had a hysterectomy for fibroids or menorrhagia or a non-cancerous diagnosis. I did put the exception down there. This is actually going to be my soapbox. We actually use an electronic medical record. We use ECW. ECW does have an option in there for a partial hysterectomy. I know that patients frequently throw the term partial hysterectomy, and many of my colleagues do too. Hysterectomy actually refers to removing the uterus. It has nothing to do with the ovaries. Someone who has had a total abdominal hysterectomy and still has their ovaries did not have a partial hysterectomy. What really a partial hysterectomy would refer to is something called a supracervical hysterectomy, meaning that the body, the corpus of the uterus was removed, the cervix was left intact. Why would you do that? Well, The most common reason is actually going to be an emergency. It's going to be a postpartum hysterectomy. You can't control the bleeding, and you've got to get that out of there. That's the most common the reason. Another would be severe adhesions. Such severe adhesions that you've got an extended operating time, and you're very concerned about the possibility of damaging a ureter because you can't dissect well, you can't get good planes. The last, which fortunately has kind of fallen out of favor, is there have been a few periods in our recent history where there were ideas that you would improve sexual function by leaving the uterus, by leaving the cervix in situ. This, in some places in Europe, still seems to be a fad. There is no data to support that. So at this point, hopefully we're not seeing that. So again, this makes a difference though, because if someone has had a partial hysterectomy, a supracervical hysterectomy, still has a cervix, they still need to have pap smears done, unlike the patient who's truly had a hysterectomy and no longer has a cervix. And again, just some pictures to illustrate that. The first was just a reminder that you can't look at the scar and know what kind of a hysterectomy was done, and I've heard that before too. So in general, most hysterectomies and most cesarean sections are done as low transverse incisions here. Sometimes you can have a vertical incision for various reasons. Sometimes in a very large patient. Sometimes where you can literally have uterine fibroids so large that the fundus is all the way up to the umbilicus. So that sometimes can be the indication for this kind of an incision, but that doesn't tell you anything about what kind of surgery was done. Again, a hysterectomy removes the entire uterus. A hysterectomy with salpingo-oophorectomy this would be supracervical, the cervix remaining intact, relatively unusual. So I get asked, well, what am I supposed to say? Well, the answer would be ovarian conservation. If the tubes were taken with it, the technical term is bilateral salpingo-oophorectomy, BSO for short. These are common benign findings that we get on PAP reports that sometimes lead to some confusion. If the PAP is unsatisfactory, that basically means that there just weren't enough cervical cells for the pathologist to be able to interpret. The recommendation is to repeat that in 2 to 4 months to allow some time for regeneration of cervical cells. It's really not recommended to bring that patient back 2 weeks later. You may get that same result again. There's nothing urgent about that PAP report. 2 to 4 months is very reasonable. You get a negative cytology, but the pathologist notes that there's no endocervical component, no endocervical cells. The current recommendations, if they are in the 21 to 29-year-old group, is to repeat within 3 years. Again, remember, this is the group that you're generally not going to have HPV results for, nor do you want them because they're probably positive and reflecting an acute infection that will clear within 24 months in most cases. If they're in the 30 to 65-year-old age group and their HPV is negative, that PAP does not need to be repeated until 5 years, unless, of course, you work for an FQHC. Or if they've got a positive HPV, in this age group, you repeat that in a year because that is considered more concerning for a persistent infection. You do not need to send this patient to the gynecologist to dilate their cervix to get into cervical cells on their pap smear. I see that fairly frequently. Moving on to the management of abnormal pap results. The big change here is that we're breaking patients into age groups, again, based on evidence-based data. So the groupings are ages 21 to 24, 25 to 29, and 30 to 65, and the management is going to change based on that. So atypical cells or low-grade dysplasia in ages 21 to 24. Cytology alone is what's recommended at 12-month intervals. If your repeat at 12 months is either negative, atypical, or low grade, you're going to simply repeat that PAP again. Again, the immune system needs to be given time to do its job. If at 24 months you've still got some atypical cells, that's the point when this patient is sent for colposcopy. If you get atypical suspicious for a high-grade lesion, atypical glandular cells, which I'm going to go into in a minute, or a high-grade result, then that patient, even if they are young, gets sent for a colposcopy right away. I guess I should ask, how many people in the room actually do their own colposcopies versus refer? Okay. All right, so I'll try and keep that in mind as I'm making recommendations. In terms of follow-up, so after 2 consecutive negative results, meaning every 12 months, at that point this patient would return to testing every 3 years until they turn 30, and then they go to the 5-year. And the next grouping would be atypicals in the 25 to 29-year-old age group. The slight difference here is regarding the addition of HPV testing. With this group, it's actually preferred to add on HPV testing if you get an atypical result. And that can be done as an add-on or a reflex PAP. If it's negative, you repeat co-testing in 3 years. If it's positive, they go to colposcopy. An acceptable option is to just repeat cytology in 12 months. This is actually what my practice does. And if negative, return to routine screening. And if repeat ascus, then go to colposcopy. Ages 30 to 65, again, what's going to be the differentiation is whether the HPV is negative or positive. If it's negative, you would do a 3-year repeat. If it's positive, they would go to colposcopy. And basically, you consider that the same as an LSIL result. Atypical glandular cells. This is a little bit different situation because we don't actually know where those glandular cells came from. So the question is, are they endocervical or are they endometrial? So to follow this kind of a PAP, you would actually do endocervical curetting as well as an endometrial biopsy with your colposcopy. If everything is negative, repeat co-testing in 12 months times 2 and then go to every 3 years. For low-grade LSIL in ages 30 to 65, again, if the HPV is positive, they go to colposcopy. If it's negative, repeat in 12 months. Why am I not? I don't seem to be responding here. Oh, there you go. Okay. Atypical squamous cells that favor a high-grade lesion, basically you treat as a high-grade lesion, regardless of what the HPV status is. There is an option in the guidelines of an immediate LEAP, a loop electrocautery procedure, which would remove the transformation zone. For those over age 25, that's typically going to be done in a patient whom you're really concerned about your ability to see them in follow-up. And I only mention that in the event that you should get a result back like that from your gynecologist and say, whoa, is this person like being really over-aggressive? You know, this is the patient who showed that hasn't been seen in 5 years and that you think is really unlikely to show up for follow-up. Most of these guidelines really are dependent on that patient showing back up for repeats in 12 months. And if you don't think that that's likely, then immediate LEAP is a possibility. So again, you know, some differentiation based on the age of the patient. For those patients that are ages 21 to 24 with, on a colposcopy, no visible high-grade lesion, observation, with cytology and colposcopy every 6 months. And this is one of those few exceptions to what I said before. If you think you've got a high-grade lesion in somebody young, then we are still looking at 6-month repeats. If you see something visible, biopsy it. And then a LEAP if it persists for 24 months in these very young people. Or if your exam is inadequate, or if you've got high-grade results on your cervical biopsy, or any grade CIN on an endocervical curette. Okay, so now here's where we're going to see if this is all making any sense. So what we're going to ask people to do is to get out their cell phones. And this is a poll. We're going to go through some cases and have the audience vote as to what they think the management of the PAP should be. How are we doing?
Almost there.
Okay, almost there? Okay, so our first case is a 22-year-old G1P1, so pregnant once, delivered once, with an LSIL PAP. She had a baseline PAP 12 months ago when she was 21, so again, remembering that we're now starting at age 21. And so now her repeat PAP is atypical. So what we're going to consider is, should we schedule her if we do colposcopies ourselves or refer if we don't? Should we repeat her PAP in 6 months? Should we repeat her PAP in 12 months? Or should we add on an HPV screen? Okay, that same 22-year-old, we've now repeated her PAP 12 months later, and we've got ascus. So should we repeat her cytology in 3 years because the trend's improvement? She had low grade, now it's down to atypical, so that's better, right? So should we just tell her to come back in 3 years? Should we add on an HPV screen? Should we schedule her or refer her for a colposcopy? Or do we repeat her PAP in another 12 months? Okay, now we're going to move on to a 64-year-old G3P3, ascus cytology, but no endocervical component on the pap smear result. A stenotic os was noted when the pap smear was done, so you couldn't get your cytobrush in that endocervix no matter how much you tried. An HPV was not done, and the pap smear report says there's low cellularity. She has a history of one prior abnormal pap smear at age 30, which was treated with cryotherapy. Are we going to repeat her PAP in 3 months with cervical dilation in order to get into cervical cells? Are we going to repeat her PAP in 6 months? Are we going to repeat her PAP in 12 months? Or are we going to reassure her that she hasn't had an abnormal PAP in 20 years and the guidelines say that we can stop doing pap smear screening at age 65? And as everyone correctly responded, the right answer for her is going to be to repeat cytology at 1 year is acceptable, or you could actually add on HPV testing for her. Personally, I would just go ahead. In that age group, you're sometimes going to have trouble getting insurance to accept or to pay for that HPV add-on, believe it or not, in a 64-year-old. I've had them rejected. Okay, now we have a 25-year-old with a high-grade PAP. Do we order an HPV? Do we repeat her PAP at 12 months? Do we schedule or refer her for cryotherapy? Or do we schedule her or refer her for colposcopy or immediate PAP? So again, our options there, if you think that follow-up is going to be, if you refer this patient and the gynecologist, I guess in this case, thinks that follow-up is unlikely, they may recommend an immediate LEAP or loop. More commonly, a colposcopy is going to be done. And if there's no CIN 2-3, they're going to be managed with a repeat PAP in 12 months, or more frequently if 2 to 3. So the last one is a 50-year-old G2P2 with atypical glandular cells on her cytology. And HPV is not showing up. Let's say the HPV is positive. So repeat co-testing in 12 months, repeat co-testing in 3 years, refer, schedule for cryotherapy, refer, schedule for an endometrial biopsy with colposcopy. And I actually put in that refer for cryotherapy one just actually to mention that that really is no longer in any guidelines. And I'm not going to pull up the app again. I think we've all got the hang of that. And obviously, yes, we don't know where these glandular cells came from, so we're going to do an endometrial biopsy to make sure they're not endometrial, particularly in this 50-year-old, as well as an endocervical curette to look at the endocervical glandular cells, and then a colposcopy.